All right, that takes us to Article 10, Di.
All right, this is the bear.
This is the bear. It's from the Emergency Medicine Clinics of North America, so it's a little more of a chapter than actually a paper. Right. And it's written as sort of a toxicologist reference material, and there is great reference material for you in here. But I don't think all of the information that's in here is really the kind of thing you need to know as an emergency physician and carry around with you in whatever leftover space you have in your brain. So I'll start with that preamble. The title of the paper is Toxic Industrial Chemical and Chemical Weapons, Exposure, Identification, and Management by Syndrome.
Killed a tree.
Killed a big tree. It's by Tomasani, A.J., French, R.N., and Walter, F.G. So 3 authors. And let's just launch right in. So, I didn't make the slide.
I did.
Warning, the article is basically a collection of 7 rather extensive tables with tons of information, and I couldn't agree more.
It is table after table of ripe for ABIM question writing kinds of data.
But I think they're going to, they're toxicologists, so the questions hopefully will be relatively straightforward. I hope focus on things like toxidromes.
I do too.
So we're going to focus on some of the highlights in these slides. So are there a lot of chemicals out there? Oh yeah, there's a lot of chemicals. Are they potentially bad for you? Yeah, they're almost all bad for you. Can exposures to individuals affect larger populations? Sure. If there's a leak, a spill, an explosion, sure they can. Do emergency personnel need to be prepared? Sure, we do, both on small and large levels. But the part that I find most, while there's lots of disaster preparedness, I would like to focus on the diagnostic part of this when recognizing smaller isolated cases. And some of those exposures can be pretty subtle. So they can be thought in terms of acuity and urgency of the medical sequelae, the immediate effects soon after the exposure, and that's when you're most likely to figure out because the history should lead you to something. Short-term delayed effects, still pretty likely that the history might tell you if you ask the right questions. Long-term delayed effects, thank you, my toxicologist, you can find those because you're going to have a hard time with that unless the patient knows and is already under care. Mechanism of toxicity, dose, route of exposure are all useful and important. We know this drug dose route, it all matters. Some of our understanding of these exposures comes from historic disasters that are out there. What are the keys? Understanding the potential of exposure routes. Is it cutaneous? Is it inhaled? Is it, ingested? Those types of things. Knowledge of the physical and chemical properties of the agents. We call those people chemists. And to a lesser extent, toxicologists. Ability to recognize toxic syndromes. That's important. What are the clinical toxidromes you need to know? And while many of us are familiar with some of these, some of the others are, because they're encountered more rarely, are less known, and that's where this article might help you. Providing supportive care, we do that. I'll do that. And then the last thing is, if there's an antidote, you don't want to miss the ability to identify it. A lot of these are weird antidotes that we don't use regularly. You're almost always going to be involved in a poison center or a toxicologist directly in these cases. Emergency exposures may be confusing. Sure they are. There might be concomitant trauma. There might be multiple victims. There might be limited information. All true. Sometimes it's nothing to do with a toxic exposure. There was a cloud of some colored smoke and everyone thought it was bad and there was nothing in it. Emergency exposures can be confusing, but when you think you've got something like that, you do want to protect your staff from secondary exposure. You do want to differentiate significant from trivial exposures because if you have limited resources and a lot of victims, you want to save the resources for the people who need them. That comes up with organophosphates and nerve agents.
Secondary.
Yep. You want to remember to decontaminate. Remember the A, B, C, D, E's of tox, right? Airway, breathing, circulation are the same, and then it's decontaminate and eliminate. So you want to remember that the D and E are different here. Notify the appropriate agencies, poison control, public health and safety, FBI if it's terrorism, those kinds of things. What are your cues and clues that a toxin may be involved? The victim's occupation, that's helpful. And their hobbies, because sometimes they do their hobbies more than their occupation, so I would add that. Occupation of close contacts. And so there's tables that are there that show long-term effects and different agents and symptoms and syndromes, and there they go. And I'm not going to go through all of these, but there's the dermatoses, the headache, the psychosis, asthma, pulmonary edema, cardiac arrhythmias, angina. So a bizarre array of things that can happen to you. The long-term effects, again, these are going to be some of the most challenging, although I have found beryllium on a guy that was missed. He was a Kaiser patient for years.
Asbestosis, silicosis, we see.
Yep. coal dust, cotton fiber. I've seen the cotton fiber. What's the other name for the cotton fiber one?
no.
I used to know all these names, but there's a specific name for almost all of them.
You
Silicosis,
remember
et cetera.
those things.
They're there. All right, arsenic.
Yeah, these are part of the tables
Yeah.
that you'll have in
Yeah.
this article. And I'm not sure, they're in there so that you have them as a resource.
Exactly. So, basic principles of toxic exposure and risk. Risk is related to the toxicity of the agent. They're minimized by personal protective equipment.
We're back to personal protective equipment.
PPEs. And duration is important. Other concerns are mixing of chemicals, lack of clear exposure data, and clinicians may need to consult multiple resources like material safety data sheets and tox and poison centers, et cetera. What are the usual routes? Inhalation, dermal, ingestion, injection. Pretty rare, but it happens. A toxic syndrome may be influenced by the route. In other words, some routes will happen slow and get you a chance to see it. Some routes might be too fast, et cetera. Some toxicants need metabolic transformation to become injurious. In other words, they're not that big a deal until they get metabolized by the liver, kidney, and then you get problems. And the table 3 here in the paper shows you some of those. In terms of toxic chemicals and chemical weapons, now you're into difficult stuff. You certainly want to be involved with personal protective equipment and decontamination, evaluation, stabilization, and potential transportation of these. You're going to need references for complete information, and you might have paper copies. In this paper, I will tell you, my favorite chart of these charts that we're referencing is the one that talks about the occupations. And not the selected target organs. Where's the occupations one?
Probably 4, 3, 4.
The occupations and their
Oh, what their
exposures.
exposures are. It's
Yeah.
in the back.
Because that'll actually give you history on the front end. See, too much.
It's table
underlining.
7.
Tables.
The last table. Last table.
So that's my favorite table because that one
Yes.
helps you get to ask the history
it's
questions.
potential
and start thinking
chemical
about it.
hazards by industry.
Yeah, that's the one that I want available to me as a reference here. All right, basic principles of PPE. You got to have your training. You got to have your standards and appropriate stuff. There are 4 levels for the ED, level C and D, and this is where you get into your little yellow suits and all of that, and we keep training our residents to do that. Details on level of PPE are not covered here. This is more disaster response kind of focused stuff, so we're not going to get into it, thank God, because there's more than enough to get into. Grouping exposures by effects is often useful, and toxidromes are where it's at. And so this is where you see a patient with a constellation of clinical clues. They're short of breath, they have blistering skin or something like that, that go into it. And Table 4 lists the examples of chemicals and their syndromes. It's
Right.
the syndromes and toxidromes that we're after.
So we'll
here.
go through some of the ones that are in the table at this point because I think this is stuff that's ripe for questioning. So we'll have those out
And
for
it's
you.
the stuff that's important. You're not expected to know all the stuff. The question is, do you recognize the clinical material in front of you? So the first one we're going to talk about in terms of toxidromes is irritant gases. A lot depends on their water solubility because your lungs are moist. So they include ammonia, formaldehyde, hydrogen chloride, the list you see there. These are inhalational exposures, and they can be local irritants and displace oxygen. So how do you decontaminate them? Generally, it's administer oxygen in breathing treatments and intubate them if they can't breathe. No mystery there.
It's pretty straightforward.
Right, that's all stuff you do. Chemical asphyxiants. So this is interesting. So this is going to displace oxygen from their environment or bind up the oxygen transport vehicles. So it's carbon monoxide, hydrogen cyanide, and hydrogen sulfide. And having seen a couple of hydrogen sulfide exposures, for example, they're all dead.
They drop.
And
drop and
usually 2
die.
people die trying to get them
Right.
before they realize you can't go in there without scuba. So there you go. It's inhalational route. They interfere with oxygen transport and may cause respiratory distress and cardiac arrest. Pulse ox
Fast.
may be falsely normal. How do you fix them? Decontaminate them, which is remove them from the other gas source and oxygenate them if they're still alive. Chemical asphyxiants, so there are specific treatments for some of these. So carbon monoxide, you get to the hyperbaric chamber. Methemoglobinemia, you're going to give methylene blue. Cyanide, you're going to give sodium nitrate and or sodium thiosulfate. And hydroxycobalamin has gotten a lot of attention, and we've been through that in a variety of venues recently. Hydrogen sulfide, possible hyperbaric oxygen, and nitrites. So these are questionable
All of
topics.
them,
So
absolutely.
this is sort of core stuff. So it's under the chemical asphyxiants. If I was going to look at this paper and look for stuff, this is stuff that comes up. Now, the cholinergics are also very questionable. They include the organophosphates and the nerve agents. Obviously, the organophosphates are part of the agricultural industry. The nerve agents are more on the terrorism, military weapon side. They can be skin and mucous membrane absorbed. The symptoms for the muscarinic, it's the sludge syndrome. For the nicotinic, it's weakness, tachycardia, and mydriasis. It says hypertension. That's variable because oftentimes they sludge themselves down to the point where they can't be hypertensive.
Right, and sludge is salivation, lacrimation, urination, defecation, gastric emesis.
Thank you.
So every orifice produces fluid, basically.
There we go. And then the CNS confusions and coma. So how do you do these? You decontaminate these, and really these are, particularly if it's a nerve agent, you definitely need to be protected yourself. Atropine and possibly 2-PAM. There's some where 2-PAM doesn't work. A few. This is the carbamates, something like that, where 2-PAM doesn't work. I can't remember exactly. I think that's the answer. Okay, but beyond that, we move to the next toxidrome, the corrosives, acids and bases, skin and mucous membranes. They're local irritants. There can be respiratory cardiovascular compromise. And then the usual things that come up are acids give you coagulation necrosis and alkali give you liquefaction necrosis. Liquefaction is generally worse and continues to cause problems as it eats through tissue. Decontaminate, irrigate, airway support. I personally think that the questions are less likely to be on the
run-of-the-mill stuff.
The organophosphates and that, because those are always out there. That's part of the lexicon of emergency medicine. This stuff, kind of part of the lexicon of common stuff. So I think they're going to go for something new.
They could ask about this, though.
Corrosives.
Hydrofluoric acid.
Hydrofluoric acid. There could be skin, lung exposure, highly toxic, binds to calcium. Pain out of proportion to exam. A lot of times it's rust remover, wink rust removal, or etching. Glass etching comes up. They can get signs of hypocalcemia, particularly if it's ingested, and cardiac arrest. Decontaminate, no emesis or activated charcoal, irrigate the skin, and then when it's the fingertips, you go for calcium chloride or gluconate. You can do it IV, you can do it for gel, and you do it until they have pain control. Hydrocarbons, chloroform, gasoline, propane, toluene. These are inhaled, sometimes drank.
Ingested. Mm-hmm.
Lethargy, cardiac irritability, because you get this sensitization to endogenous catechols, so they can get tachycardic and PVCs and dysrhythmias. You want to decontaminate them, oxygenate them, supportive care, and avoid epi, because you're just going to provoke dysrhythmias. Toxic alcohols, I think I'm not going to spend a lot of time on this. Mm-hmm. This is also something that we're all well aware of. There are various toxic alcohols out there, and we have new stuff to treat them with in terms of the 4-MP that comes up. Now we get into some miscellaneous hydrazines, seizures, skin, eye, and mucous membrane irritation. So you're going to do supportive treatment. The blistering agents like mustard gas and phosgene comes up sometimes. These can give you delayed symptoms. You want to decontaminate them, wash thoroughly, and supportive care. Again, nothing particular. So many toxins are treated only with decontamination and supportive care. But some toxins have specific antidotes, and failure to recognize the toxin in the antidote can be a problem. So antidotes may need to be stockpiled if you're near an area where you could have this problem. And Table 5, which I think is an important one, lists the antidotes and the rationale for their use. I'm not going to drag you through it.
We've summarized it in the slides if you're interested. Yep. They're all there for you.
So I'm going to let you look at this one. I'm going to move on to this one, and I'm going to get out of there. So Table 6 in this lists other hazards that come with toxicity
these are
and some comments.
These are a little bit sort of out of our usual purview, so I don't think these are particularly helpful.
Children and pregnant women have a few exposures that may be harmful even in small doses. We've already made reference to the 2 pills can kill thing. There are teratogens and carcinogens. Impact of developing fetuses may or may not be known. Children are more vulnerable to some of these. And some special considerations in terms of toxic chemicals and chemical weapons. To minimize exposure, fresh foods and diet, okay. Avoid vapors from solvents and paints.
Ventilation.
And I know people, back to the fresh foods, who are just fanatical about washing their apples and their fruit, and they're sure that they're getting poisoned by this stuff. And there's probably some truth to that. Minimize over-the-counter and herbal medications. I had to just I saw a guy just the other day at Stony Brook who was, one of these weightlifter, healthy sort of 45-year-olds who came in with tachycardia and a bunch of PACs, and basically turned out he had a caffeine overdose from the green tea extract, the Boost drink, and the Monster. It's like, and I had to explain to him that, listen, if you're in GNC, how do you know you're wasting money? You're in GNC. That's how you know. If you're in there, you're wasting money. Weight gainer 5,000. Okay, it's called an amino acid. All right, I digress, and I'm sure there are people out there
So
thinking,
you could minimize your exposure by avoiding smoking and alcohol.
And I'm going to have a smoke as soon as we finish this, while I contemplate that. Take care with some personal care products, and if I had a drink, I'd have that too. Minimize workplace exposures, and that even applies to us. We have toxic chemicals and material safety data sheets. Have you ever had JCO come through and ask for your material safety data sheets?
Yes, I have. Fortunately, someone had just told me where they were. I don't know where they are right now, actually.
Use your PPE and avoid transferring chemicals from work to home. I think that's a good plan. Try not to fill your truck with chemicals.
That's a good idea.
So, in summary, we're going to end up here. Many chemical agents may cause toxic effects. Basic decontamination principles. So remember that the D and E of the ABCDE is decontaminate and help eliminate. Syndrome recognition, and we went through some of the more unusual syndromes. We went through the organophosphates with the nicotinic and the muscarinic. We went through the asphyxiants, because I think those are good ones to go for. Mm-hmm. But toxidrome and syndrome recognition is really what's going to guide your therapy and thinking. And I personally think that before you call a poison center, if you really think it's occupational, you need a chart like that table.
The job with
the
what
jobs,
exposures are.
the workplace with the exposures, table 7. That's the kind of thing, because you'd like to have information before you call Poison Center. And some agents have specific antidotes, and you want to know if this is one of them. And although it's not on here, my last point would be, use the Poison Center on these, get help. This is not the kind of thing an every ER doc is expected to know off their cuff.
Mm-mm.